Good morning, all. I'd like to welcome you all to today's session of the 8th Annual Scientific Meeting of the OSU Nationwide Children's Hospital, CCTS. My name is Cynthia Carnes, and I serve as the project leader on the CCTS's KL2 program. The KL2 program is an educational training program for junior faculty, and we have developed a number of training programs to support the development of scientists at all stages of development at OSU and NCH. Not only do we support the overall training of the next generation of clinical and translational scientists, we are also training them to be excellent communicators and be able to communicate about their research to others. This includes communicating with other scientists, mentors, the public, and the CCTS has made a significant commitment to building the communication skills of our trainees. In addition, these trainees are open to all of you as members of our community. Examples of training that are supported by the CCTS include training sessions on how to give TED-style talks, elevator talks to potential investors. All KL2 scholars complete this training and then present an overview of their work at the OSU COSI collaboration, the STEAM Factory in Franklinton, during Franklinton Fridays. It's my sincere hope that we'll be able to resume these as soon as possible. It is a real joy to see members of our research community be able to interact and communicate with members of the Franklinton and Columbus community, from young children to older adults who come in to engage in activities, have snacks, and talk directly with scientists representing their work in an informal and accessible way. It's been fun to me to sit there and see the analogies people come up with to communicate their science, whether it's using the analogy of army guys as immune cells protecting us from pathogens, or adipose cells as the bad guys. It really does bring science to life and does get the audience's attention and gets them engaged. Most recently, the CCTS sponsored a workshop from the Alan Alda Center for Communicating Science. I myself always loved watching Alan Alda interact with scientists on scientific American frontiers. And the idea of the center that he established is to use conversational approaches to make science interesting and accessible to the public. Somehow the excitement and the fun that we sometimes feel as scientists gets lost in the communication, especially with non-experts or non-scientists. I believe when we talk past or over other people, it impacts their ability to hear, to understand, and engage with what we are trying to communicate. The real world impacts of these communication gaps have become more evident during the ongoing pandemic. I would argue that our inability to communicate in a way that builds trust between clinicians and scientists and the communities that we serve has had a negative impact on the progression and duration of the pandemic, often with heartbreaking results. In addition to the COVID-19 pandemic, we've also seen the impacts of systemic racial disparities and health inequities as COVID has disproportionately affected some communities, particularly those of Indigenous peoples and people of color. Health equity is a state where everyone has the opportunity to be as healthy as possible. And we see that longstanding systemic health and social inequities have put many racial and ethnic minority groups at an increased risk of becoming sick and dying from COVID-19. It is clear that some racial and ethnic minority groups are disproportionately affected by COVID-19, and inequities in social determinants of health, such as poverty and healthcare access, are interrelated and influence a wide range of health outcomes. Some experiences are common to many people within these groups, and social determinants of health are incredibly impactful on economic, physical, and emotional health. It is my belief that to achieve health equity, we must address barriers that prevent everyone from having a fair opportunity to be as healthy as possible. My firsthand experience with such a barrier happened to me when I was in high school, when I accompanied my Spanish-speaking grandmother to the doctor for an episode of acute knee pain. She had limited English. The doctor had very, very limited Spanish. I would add that my grandparents lived in El Paso, which is a medically underserved area of the country. It was a painful process to get through with me trying to translate back and forth. I guess the thing that struck me, and this really captures my grandmother's sense of humor, is her explaining to the doctor that it was her knee, in her very slow English, it was her knee that hurt, but her hearing was fine, as his solution was just to speak very loudly at her in English. It was a real eye-opening experience for me. A few years later, my 82-year-old grandfather, also Spanish speaking, broke his hip and became delirious after discharge. When we contacted the orthopedic surgeon, he told my grandmother that my grandfather needed to see a psychiatrist for his delirium, rather than evaluating what actually was a post-operative infection. And as a pharmacy resident at the time in Salt Lake City, it was a very frustrating experience for me trying to remotely facilitate appropriate care for him. And again, that really, I would say, even at that early point in my training, got me thinking about health disparities. So while health inequities are real, I think some of these inequities that we see do result from breakdowns in communication. And clear and understandable communication is a barrier to building trust between the people that we serve and healthcare providers. The proliferation of false information that we see now is difficult to combat without the ability to communicate in a compelling and understandable manner. It has become increasingly clear that there is a lot of false information circulating that is widely believed. And as scientists, we have to ask ourselves, why is that false information more believable than what we consider to be real science? Much of this is presented, this false narrative is presented with a strong emotional component that really pulls people in. It's very compelling information. These false narratives are often told with very simple and clear language that people can understand. What is striking to me is that these are the techniques that we know make actual high quality science communication more engaging, emotional content, clarity of speech. This makes our information more believable and more memorable to the audience. We should challenge ourselves to communicate in an interesting and compelling manner moving forward. One emerging barrier in managing the ongoing pandemic beyond mask refusal is vaccine hesitancy. As healthcare providers and scientists, what is our obligation to be able to communicate clearly and effectively with our own communities, our personal communities, the patients that we serve, our coworkers? What is our responsibility to listen to them in a careful and respectful manner? What is our responsibility to understand the basis of their hesitancy so that we can speak to their concerns? You know, I believe we're going to have to do all of these things. That's our part of the puzzle, in part, to move forward in a way that improves access to healthy outcomes for all of us. So where am I going with this today? I want to remind all of you of the excellent communication trainings that the CCTS offers as part of its educational mission. Many of our trainees describe the outcomes of these trainings as transformational, not only allowing them to communicate with the general public, but even with their own families about what they're doing. You know, one of our trainees told me that it was the first time at Thanksgiving that his family understood what he was doing at work all day. So I do think it's important for us to be able to talk about science in a way that makes it living and real to others. We're going to hear some excellent talks today that discuss health disparities and health inequities. We're also going to hear about ongoing research and programs to address them. I am so looking forward to learning more about these today during our sessions. First, we're going to hear about the RADx UP, I hope I'm saying that acronym correctly, initiative. And really the goal of this, as I understand it, is to understand the factors associated with disparities in COVID-19 morbidity and mortality, and to lay a foundation to understand ways to reduce disparities for those who are underserved and vulnerable, or for those who are disproportionately affected by this infection, those who have the highest infection rates, the highest rate of complications, or highest rate of poor outcomes. So understanding this, you know, I think this is going to take a really careful understanding of the social and other barriers, economic barriers, et cetera, that are preventing people from accessing good care and getting to good outcomes. Later, we are going to hear about broadband access in Appalachia. This is a topic that became very relevant to me, and I'm sure to many in the audience, while trying to do telehealth appointments, especially early in the pandemic with patients. And what we see is that some of our patients have very limited broadband access, and it does impact their ability to access high quality care remotely. I believe this is an aspect of access to healthcare that is often overlooked, but one that clearly has real impacts on our patients. In the second session, second part of the morning, we will hear more about COVID-19 with a focus on public health response and lessons learned, wrapping up with a talk on the impact of COVID on the research community. Just this morning, the Chronicle of Higher Education in their daily update had a nice summary of an upcoming article discussing the impact of COVID-19, the pandemic, and the effects that we're all dealing with on the progression of academics in their careers, with a focus on and results showing that women are disproportionately affected by time spent on non-work activities, whether that is homeschooling, home care, caregiving for others, and I think it's incumbent on us to think about how do we best support our trainees, our junior faculty during this time of disruption. And I know we'll hear more about activities that are ongoing at OSU and NCH to address those later this morning. So while the ability to conduct research has been adversely affected and there are real challenges, many of us are struggling, there are clearly actions that are being taken, I'm very happy to say, that will help us move forward and move our scientists forward. I am looking forward to an excellent session this morning. I'm looking forward to learning more, and I thank you for your attention. Enjoy your session.
All right. Thank you, Dr. Carnes, for those great opening remarks. Our first speaker today is someone who really needs no introduction. Dr. Elettra Pesquet is the Marion Ann Rowley Professor of Cancer Research at The Ohio State University and the Director of the Division of Cancer Prevention and Control in the College of Medicine. And she is internationally known for her work in intervention research directed at cancer prevention, early detection, and survivorship issues, with over 400 peer-reviewed publications to date. Her awards are really too numerous for me to list, but highlights include being appointed a member of the National Cancer Institute's National Cancer Advisory Board by President Obama in 2016. And in 2019, she was appointed as a member of the Ohio Commission on Minority Health by Governor DeWine. She has been tremendously successful in establishing networks for community-based participatory research, particularly in rural and underserved populations in Ohio and Appalachia. And so when NIH put out a funding opportunity to address COVID-19 disparities in underserved populations, we were very fortunate to have the established infrastructure to build upon from the work of Dr. Pesquet. And one last final note, I recently read through the editorial that Dr. Pesquet wrote on her experience as a COVID-19 patient. And I was very moved by both her openness and strength as she battled through the illness, continuing to lead Zoom calls on her iPad in her hospital room. The RADx sub-study that Dr. Pesquet will present today has a lot of talented people on it, but not everyone worked together previously. Yet we were all inspired and honored to be a part of this work, and we quickly coalesced under the steadfast leadership of both Dr. Pesquet and Dr. Jackson. So without further ado, it gives me great pleasure to introduce Dr. Pesquet.
Thank you very much for that introduction, Guy. And it's just been really great to work with everybody on our RADx here. And I really enjoyed the opening comments. Cynthia, you speak to my heart. I've been doing disparities research for over 3 decades, and you really hit a lot of the important points. And so I'm really pleased today to present a little bit about the Ohio State RADx UP COVID-19 Large Network Center. So let me just define before we start what the RADx stands for. We like acronyms, and the National Institutes of Health also loves acronyms. So it stands for Rapid Acceleration of Diagnostics, and the UP on this stands for underserved populations. And what you will hear in my presentation in just a few minutes is a little bit about the different parts of RADx up, RADx and RADx up that exist. And we do have another RADx initiative funded here at Ohio State with Dr. McIlerney. So Ohio State really is not only locally moving on testing and vaccination and other and treatment and other innovative things in COVID-19. We are participating on the national front as parts of the RADx Up initiative. So also, as Guy mentioned, Dr. Rebecca Jackson is the contact PI, and she sends her regrets today. She is in another national meeting and can't attend. And so she and I work together on this initiative, and I'm pleased to present on both of our behalf this morning. So wake up the screen. There we go. So the overall goal of RADx Up is to address and reduce the disparities in COVID-19 education, testing, contact tracing, follow-up, and treatment. And we will now call all of those components the COVID-19 testing components among minority, underserved, vulnerable populations. And so you will see this also abbreviation of MUVPs. And so it does stand for a minority, underserved and vulnerable populations. And that is really, in NIH's mind, the first phase. Many of you are saying, well, we're already starting vaccination. Well, phase 2 is going to focus on leveraging what you've done in phase 1 to then ensure equity in vaccination. So let's start with a little bit of background. Again, Cynthia gave a great background in terms of the impact of COVID on the populations that we're focusing on. But let's just review a little bit. So as of January 21st, last week, over 24.5 million cases of COVID were diagnosed, and over 400,000 deaths occurred in the last year. And Guy said, I am one of those cases. And because of the great treatment options that we have here at Ohio State, I am not one of the deaths. And I did participate in a clinical trial. I do clinical trials, and so I was very excited to actually be able to participate in a monoclonal antibody treatment trial. So I really do want to thank those here who quickly treated me so I did not become a fatality. COVID-19 disproportionately impacts minority, underserved, and vulnerable populations for many reasons, and a lot of the reasons are because of the fact of the social determinants of health, the housing conditions, the access to health, the finances, the type of work that they do, both that puts them into a little more closer contact with each other, plus does not allow them opportunities for social distancing or even time off if there are exposures or illness. So we are defining, minority, underserved, vulnerable populations as not only minority populations, but older adults, those with comorbidities, those of lower socioeconomic status, and residents of rural areas. And this fits perfectly with the definition that the Ohio Department of Health uses for minority, underserved, vulnerable populations. And I will talk a little bit more about our interaction with that very important work that a group of OSU researchers and Ohio Department of Health did in relation to the minority, underserved, and vulnerable populations in the state of Ohio. And as we've talked about, these populations are less likely to get tested, and therefore this, we believe, and we have some evidence now that this is extending to vaccination. So again, the big RADx underserved population, they conducted, they are 2 phases, as I mentioned, and they released 4 FOAs, like requests for applications, that focus on COVID-19 testing and in community engagement, that in the application you had to leverage existing populations. And Guy mentioned that existing partnerships. Sorry, Guy mentioned that we leveraged our network that we have in the Cancer Center. We have a community outreach and engagement arm in the Cancer Center through our Center for Cancer Health Equity. And we have relationships across the state. In the CTSA, Dr. Jackson has also established a network across the state, most notably for the HEAL study, but also for other activities. And so we put those 2 networks together, and that is what we leveraged as our existing partnerships here in the state of Ohio. So when this was submitted or issued, phase 2 was anticipated within 1 year. So, we submitted late summer, so they thought that we would be up and doing phase 2, which is vaccination by summer, early spring, or late spring, early summer of 2021, tentative notice. And the goals for phase 2 are to enhance your infrastructure, expand partnerships, and serve as a resource for, I don't know why they say vaccine trial, because we're doing vaccination, but it could be trials about how to get people vaccinated. So this is, again, the timeline for the National RADx Up initiative, and what the sites will be doing: build the infrastructure, rapidly implement testing, and then, as I mentioned, summer, integrate new advances and expand the populations. Again, focusing here on vaccination and here on testing. Who knows if this timeline is going to change? We have a new administration who has a very aggressive target for vaccination. So, we have not heard anything yet. So again, this is the 2 phases, as I mentioned, that we have not been getting any new information on when phase 2 will start. Importantly, at the heart of RADx Up is the community. And as you can see this here in this circle diagram. And really the heart is our underserved, minority, and vulnerable communities. So the strategies RADx Up as an initiative is focusing on is expanding the capacity to test broadly for COVID in highly affected populations, including asymptomatic persons, to deploy validated point of care tests as available, and as available, as validated, as accepted self-test and saliva-based methods, and I'll talk a little bit about that latter in just a few minutes. Inform implementation of mitigation strategies based on isolation and contact tracing to limit community transmission. That is a big part of this, is to implement these mitigation strategies. Understand factors that contribute to COVID-19 disparities, and then implement interventions to reduce these disparities. And then implement or establish an infrastructure that could facilitate evaluation and distribution of vaccines and therapeutics. So these are the strategies. These are sort of form the framework for what all of the centers in RADx Up are doing, again, with the community at the heart. So there were 39 projects funded in phase 1, and different types of projects, but you can see it extends from the Northeast all the way across to the Southwest. And there are some in the middle of the country, not so much here in the North, but we've got some in the South. The star here at Durham indicates the coordinating center, which is a joint effort of Duke and UNC Chapel Hill. And those of you who follow basketball are saying, what? But in science, it does happen, just like we work with Michigan a lot in term for science. So again, you know, the goal of RADx Up is to help those most impacted by COVID-19, researching different patterns in different communities. As you can see, we have, you know, a whole swath of different minority, underserved, vulnerable populations across the country. We'll be identifying differences in infection rates, disease progression, and outcomes. And again, because we have such a range of sites and populations, developing strategies to make testing easier for communities that need it most, and informing the national strategy and response to COVID-19 to strengthen and improve the health of all our communities. I do want to mention one thing. Across all of these sites, you can see here San Diego got 2 awards. They're doing different things and focusing in different populations. And as we talk in a minute, you'll see that you'll see sort of the study design that we're doing. And I will tell you that the RADx Up initiative is not one where everybody has to follow the same protocol, and that's good and that's bad. And maybe, you know, we can talk a little bit about that in the questions for those of you who are thinking about research and joining national initiatives, what the good things and what the bad things are about that. But we can move on to that in a little bit. So again, the goal of RADx is to help those most affected by the pandemic. And these are, you know, when I started, I said that RADx Up has different parts. So this here is us right here in the blue. And then this is RADx Tech to look at point of care home-based and tests for COVID. These are advanced technology platforms, testing platforms, for rapid scale up or expanded geographic placement. And then this is RADx Radical. I don't know who came up with these names. Support new non-traditional approaches to address current testing gaps, et cetera. So you can see that RADx Up really is expansive, varied, et cetera. So we have 2 categories of research: learning how to increase testing across the communities, understanding the unique needs of the communities, and then helping communities prepare for vaccine opportunities. So we are really focusing on this. All right. So let's move now. You've got the big picture of RADx Up. Let's move now to what we are doing here at Ohio State and what our RADx Up large network site is doing. So we are going to accomplish the goal, which I showed you earlier, through the delivery of a community-based participatory research integrated program that focuses on multi-level barriers related to the disparities in the testing components. And these multi-level barriers can be at the individual level, the social level, the community level, the health system, or broader contextual level barriers, for example, policy. And what we're doing, as I mentioned earlier, is built upon our long-standing partnerships with the communities, but we have also had long-standing government partnerships. So this is really an academic community government partnership. And it is what made this so, I'm going to put in quotes, easy to conceive of, and is facilitating what we do. We are using an implementation science design, and I'll explain a little bit more about implementation science. It's something that's relatively the new kid on the block, and I am very excited about implementation science designs. I've been doing research for a long time, since the early 1980s. And, we started, with our case control and our cohort studies, and then the gold standard randomized control trial at the individual level. Then we moved to group randomized trials, looking at units, for example, clinics or schools, in doing our intervention research. And now this implementation science allows us to teach the clinics how to take better care of their patients, teach the communities how to take better care of their residents. And with all my work in the community, that is exactly what the community has been asking for. And implementation science gives us now the tools, the designs, the methods, the outcomes to be able to do this. And it is very acceptable to the community. It has intricacies in design, and it takes us as scientists a little time to think differently about what we're doing, but I think it is the way that we need to work in order to truly address disparities and to have what we do stay in the communities and not leave when our grant funding leaves. Okay, so how is this innovative? I mentioned that there were OSU researchers, Taslim Padomsi and Juliana Nemeth from the College of Public Health, that worked with a team from ODH. And also there were folks from the Kirwan Institute that also worked with ODH, and also Dr. Elizabeth Root from Geography. And they identified at-risk counties. And we took all of those data that they put together, and we identified 12 counties that we wanted to work with. And we picked these counties because they contained multiple census tracts based on this study that OSU ODH did, that have disproportionately high concentrations of minority, underserved, vulnerable populations at extremely high risk for COVID and bad outcomes from COVID. And these census tracts also had no or few COVID testing sites. There might be some in the county, but not necessarily as accessible in these census tracts. And then what we did was we adapted, and in the process of adapting highly successful interventions for cancer care that we have conducted for multiple years in minority, underserved, vulnerable populations. And these interventions use a multi-level community-based respiratory research intervention approach, again, grounded in these implementation science frameworks, which is put all together to address the COVID pandemic. I mentioned earlier that, again, we're focusing on these 12 counties, but these are where we have strong established networks, both CTSA and or OSU Cancer Center. And we have a rich history, both of us do, in collaboration with the community to address disparities. These 12 counties are a mix, I'll show you them in a minute, of urban, rural, and Appalachian populations, all which include a sizable number of our population of interest. And we will be utilizing a novel evaluation strategy that includes data from a newly developed statewide COVID-19 registry that Dr. Elizabeth Root is working on, that can identify hotspots and assess our impact on COVID testing components with novel geospatial methods, again, and as well as with a focus on social determinants of health. So we're not looking at the individual person level, we are looking at the census tract or at the county level. So our aims with all that background are to implement this multi-level intervention that's built on these interventions I mentioned, and I'll tell you a little bit about what they are, and to increase COVID testing. And the primary outcome is COVID-19 testing, as I mentioned, at the county or the census tract level. Secondary outcomes are knowledge, results, and follow-up and contact tracing for positives. Then we will assess the impact and sustainability of the intervention in our different populations. And then aim 3 is really focusing on dissemination of successful strategies throughout the state with our close connection with ODH and other agencies. So this is our organizational structure. There is Dr. Jackson, myself. We have community advisory boards, data safety monitoring board. Dr. Salisbury heads up our ethics and human subjects unit. Great resource for us and really hands-on. Celia DeGraffenreid is our project director. Then we have 4 units. Dr. McIlerney leads our evaluation unit, which is really the qualitative team. Very busy right now drafting our key informant interviews. Dr. Norris, Dr. Young, and Dr. Moeller over the testing unit. And then Dr. Brock, who you heard from this morning, and Dr. Root are over the statistics and data management unit, as well as Greg Young or the data management team. And then I'm over the community engagement intervention unit. And you can see we have a combination of navigation and community health workers, which is really at the center of this. This is a hub and spoke model. Just shows how we are operationalizing out in the community. So here is the hub here, and then the spokes are, we've divided the 12 counties into 4 regions, each with community testing and data coordinators. And then each county will hire 2 community health workers. And we have identified community organizations in each of these counties that will hire the community health workers. We are working to give them a subcontract from the grant so that they can hire local people, because it's local people understand local issues and can work locally. So we are being evaluated using a step wedge group randomized trial. The group is the county. My view. And we are, as I said, using implementation science framework and overall program evaluation. So here's the counties that we picked, the 12 counties. So this hatched lines in the counties are the 32 counties in Ohio that are part of Appalachia. The study counties are bracketed in the darker color, and the green indicates a designated rural county. So you can see we're here in the Northwest, the North, Northeast, the Appalachia Central, and then here in the Southwest of the state. And as I mentioned, we have 3 waves with 4 counties in each wave, with 1 county from each of the 4 regions, which are how our hubs are set up. And you can see that we're balanced with rural and urban designation, not only in each of our waves, but across the 12 counties. So what is this intervention? So we, for many years, have been using what's called the continuum of care patient navigation, which utilizes community health workers who go into the community, educate the community by using community channels that are established and that are well known to the community health workers. And when we work with some communities that don't speak English, we have bilingual community health workers that can speak to community residents in the language and the custom that they understand. The community health workers educate folks about the condition. So I'm going to use our example we've been doing for many years with mammography. Community health workers educate women about mammography, about why they need one. And once they have a woman who needs a mammogram, the community health worker connects the resident with our telephonic navigators here at Ohio State. And again, we have bilingual navigators and culturally matched navigators. The navigator figures out how we're going to pay for that mammogram. Does the woman have insurance? Do we need to get her into the marketplace? Will she qualify for the Ohio Breast Cancer Detection Program, or we, the James, are we going to pay for it? Then where is she going to get the mammogram? Is there a freestanding facility, or is she going to be scheduled for one of these sites when the James mammogram comes to that community that we plan a year ahead? Then the community health worker and the navigator make sure there are no barriers to the woman keeping that appointment, assist her to get there, assist her to understand the results. If it's positive, facilitate treatment all the way through to survivorship. So that's the model that we are using. We are adapting that for COVID. And so the community health worker really is a vital part of this team. They will be from the community, as I mentioned, educate the communities. We will provide them with PPE to be able to interact with community residents as safe. They will link community members to testing and distribute educational materials. Also link community members to basic needs if they need food, housing assistance, etc. Our navigators know how to do that already. We've been doing this for years for cancer, and the same problems and the same solutions can be brought here. They will assist with contact tracing, as the county health department indicates, and they will ultimately connect members with testing sites. So the other part that we're focusing on is enhancing appropriate testing. And so we have estimated that about 20% of the populations that we will work with will not have ability to pay for testing. And so we are gearing up under the direction of Dr. Norris to provide testing to the uninsured using our OSU saliva-based platform that the students and faculty are getting every day over at Jesse Owens Stadium. And we're going to be working on pop-up testing, mobile testing as appropriate, and interacting with the local clinics, the local health department, and facilitating additional testing opportunities in those census tracts. We'll also provide telementorship to providers to facilitate, as we heard earlier, correct information, understanding the correct information. And then the Ohio Needs Assessment that ODH and OSU partnership created will assist us in understanding the needs of each population. And most importantly, we will work closely with community coalitions, county level community advisory boards, and our community partners to evaluate, implement, and disseminate everything that we're doing so that they can continue doing it when we're done. I mentioned we partnered with the state to look at the prevalence of COVID infection. We're currently working on a surveillance strategy, and we did, as I mentioned, worked with the ODH Office of Health Equity to identify and assess the needs relevant to COVID-19, et cetera. OSU researchers have also conducted and continually update excess death analysis that links with vital records. Data for our primary outcome will come through the ODH through the Ohio Electronic Lab Reporting System as part of our partnership with ODH. And other partnerships that we are leveraging include Recovery Ohio, Innovate Ohio Platform, and the Ohio Association of Community Health Centers. So this is my last slide. Where are we? We have sought and obtained initial IRB approval. We are establishing partnerships with the community clinics, the healthcare organizations, or community organizations who are responsible for hiring the community health workers in each county. And we've about got that done. We're just working on the paperwork with the MOUs and the contracts now. We're obtaining data for the community assessment. We have pilot tested the key informant guide. That's just about ready to go to the IRB. And we will begin our first wave in late January or early February is the plan right now. And I can tell you that a lot of the communities are very excited. They want to get started right now. So thank you for your attention. And I am going to stop sharing so that I can see everybody. And I'd be happy to answer any questions. And thank you again for inviting me, and appreciate the opportunity to share.
Thank you very much, Electra, for that description of the RADx Up Ohio intervention, as well as the broader RADx Up research community. It's really inspiring to me to see how the research community, both locally and nationally, really rallied and pooled expertise from multiple disciplines to address the challenges posed by this pandemic. So everyone, we'll open up for questions. We have about 13 minutes. And so if you can enter in any questions into the Q&A or the chat, and then we'll go ahead and ask those. I'm going to start it off with a question of interest to me. And so a big theme for our CTSA, our CCTS annual meeting this year is the kind of rapid response and the ability to pull resources together quickly, and how the CCTS helps facilitate and enable that. For me, I consider myself a team scientist, and I'm looking at the RADx Up composition, which you showed earlier, and there's a lot of teams there that are included in the RADx Up, including intervention and testing and statistics and Dr. McInerney's group. And but not all of us had worked together before. And we put this together very quickly. As you see, there's a very rapid turnaround. So and you've led teams successfully for many, many years. And so I'm just wondering if you can maybe talk a little bit about some of the strategies and guiding principles that you adhere to kind of to ensure success of the different teams, and how that's kind of manifest through the working together in the RADx Up.
Yeah, that's a great question. So you're right. I have done team science for a long time. The Centers for Population Health and Health Disparities, that was a big focus, and we did that for about 12 years. Team science was a big aspect of that. And how do you successfully do it? Well, you get good people, you bring together good people who are knowledgeable and expert in their field. And my philosophy is, first of all, you let them do what they're good at, and you don't mess with it. It's just like I would not go in the operating room, right? So you let people who are good at what they do it. So you're good at statistics, you do it. But you have to have sort of like the conductor then, who keeps their finger on the pulse and lets people do what they're good at, but knows also when they might need help or when something just is not quite right. And really the glue to everything, I think, is communication, trust, respect, and everybody is focusing on a common goal. And, we have a lot of meetings, as you know, in RADx Up for all of these units. But what we've added are these liaisons from each of the other units that go across. And so we bring a lot of issues. And so I think pretty much everybody should know sort of what the other unit is doing. And that's, you're the expert in statistics. How are you going to, do that? Abby's the expert in the testing. And so it's like, help me understand what you're doing. And that's also part of transdisciplinary teamwork, is that you learn the common language so that you can explain what everybody else is doing. So I hope that answered your question.
Oh yeah, that was a great answer. Yeah.
I want to just mention one thing, if I can, because I mentioned the good and the bad about doing, these big, sort of initiatives. So the good is, and as you saw from the map, we're part of this big RADx initiative. The good is that there are many different populations and we can see how this works across different populations. We can learn from other people, but some of the bad is that, you know, we were able to write everybody wrote their own design. And there's about 6 or 8 of the sites that are using implementation science. So as you heard, we're doing this at, you know, at the county level, and you know, that's good because we're going to have a lot of different protocols. But the bad is because we have a data and coordination center, they want to do common data elements. And our design, as well as the others who are doing similar designs, we're not receptive in our design to doing common data elements the way that they have written the common data elements. And so that becomes a problem when you don't have the, you know, one protocol and everybody doing the same thing. And you know very well, Guy, that we're struggling with how to deal with that right now. And I believe through communication again, because there's something like 250 sites really. With communication, I think we can come to a nice resolution. And so we are starting that communication tomorrow afternoon. A group of us who are doing implementation science design are talking with the coordinating center to try to figure this out.
Well, that was not only a great answer to my first question, but you really kind of guessed my second question already and answered it. So thank you for that. Yeah, I will just say that it has been, it's interesting to see you've got the team dynamics on the local level and people working together and trying to figure out how to, and the communication on that, which is a fairly sizable lift on its own. But then we have the communication on the national scale, a whole nother dynamic. And you're right, everyone is doing different things, and poor coordinating center is tasked with pulling these together. But the communication is the key, and you have to reach out and understand while everyone's working towards a common goal under a unified theme, that everyone maybe approaches slightly differently. And that's good, because there's that heterogeneity means that we can answer a diversity of questions. But, you know, and part of the process, and then the other thing on top of that is this is a rapidly changing situation with the pandemic. It's not the same situation that it was 6 months ago or a month ago. So we're constantly having to make sure that we stay on top of it and address it. And I think you hit on really a lot of really great points about team science and the importance, what are the important aspects, because it is a challenge to get everyone under, you know, unified. But if you can really get them under one common goal, and let's say let people do what they're good at, with the respect and but also knowing how to make sure that everyone is working towards that goal, then we can accomplish great things. All right. So does anyone, again, I want to open up the floor to any other questions that that folks have. Always a challenge in the day and age of Zoom.
So the other thing we always face, and this is not just in this initiative, but we also face in the cooperative clinical trials groups, you know, and a lot of things that we do, is making sure that we can address people who don't speak English and include them. And so here in Ohio, it's in Columbus, I will tell you, our community partners have told us that there are about 30 different Asian dialects spoken here in Columbus. And we also have Spanish, we have Hispanic residents, and we have Somali, Nepalese, and other, you know, refugees and immigrants. And we need to make sure that we are able to accommodate them. And that's another thing that we are working with, not only on the common data elements, to make sure the common data elements reflect our Ohio population in the data we're collecting, but then make sure we can translate all of our documents into the language. And there's a lot of rules now in terms of human subjects approval for that, et cetera. So that's really, you I want to make sure that everybody's included, but there are a lot of roadblocks, regulatory roadblocks and other roadblocks that often come up to us trying to accomplish that goal. And that is going to happen now.
Yeah, you bring up a lot of, it is, the diversity and the importance of meeting the community's needs. And it's not something that I'm an expert on as the biostatistician, but I realize the importance of it. And I think that's part of what you mentioned is that, with these liaisons and us then being able to understand, people who come from different backgrounds, just the importance of the dynamics that are going on and the work that's being done. And so I saw that there was maybe a little bit of difficulty in putting some questions in the Q&A, but if the chat, if you can't put your question in the Q&A, just please put your question in the chat.
People also think about, low literacy, and that's the other thing that we're working on with our questions. And yeah, sometimes that's a battle to make sure people understand. You can't use big words like immunocompromised because, not everybody understands what that means.
Oh, and I did see one question. I'm sorry that I kind of missed this. This is from Dr. Carnes. She asks, are there lessons learned that could be extended to other widespread health issues? Well, that's a great question.
Well, definitely. The strategies that we're using, the blueprint can apply to any condition. So we're right now in 6 counties in Appalachia, 6 counties in Kentucky doing, trying to increase colon cancer screening. Colon cancer is vastly preventable, but we aren't screening. And so when we go to the clinics and teach them how to improve the uptake of colon screening, we tell them, what we're doing here for colon, you can do for diabetes, you can do for any health condition. It's a blueprint. And if it's a change of mindset and it can apply to any health condition in any population.
And I had one more question actually that was about, you talk a little bit about the importance of partnering with the community and having good communication with them. And in particular, now we're talking about where to put the pop-up units and the testing sites and why it's important that we communicate with them on that particular issue.
Right. I mean, we don't know every community. And, I always like to say I'm from New York City and, I don't know the Appalachian community, for example. And so I rely heavily on the community members who have lived there forever. They know, what will be acceptable to the community, how to say things and where to go. That, we don't know, not being from that community. So you have to take time to listen. And I found that extremely important. And my colleagues that I've been working with, my friends in Appalachia I've been working with for about 18 years now, they know that OSU is there, that we don't, helicopter, we don't come in just for our grant and then leave. We've been there, steady presence for 18 years. And it makes a difference to them. And we don't only do our research, so we've helped them write over 50 community grants where the money stays in the community and addresses their needs. And it's true, and it's a relationship, a bidirectional relationship that we take pride in and is very important to us to continue and to maintain.
Well, thank you again very much, Aletra, for taking the time to come and give us a talk. We really, really appreciate your time. And now I'm going to hand the floor over to our next speaker, and Dr. Lang Lee is going to go ahead and introduce him. So thank you very much.
Thank you.
Hello, this is Lang. I would love to introduce Dr. Raghu Macharaju. Dr. Maturaju serves on the faculty at the Ohio State University in the Department of Biomedical Informatics, Computer Science Engineering, and Pathology. He is also playing a significant role as a principal data scientist of the TDAI, Translational Data Analytics Institute. And also he's administratively, he's the vice chair of the growth in the computer science department. Uh, in the scientific research, his research have in many years has been focusing on the computational biology, bioinformatics, and their applications on imaging, especially pathology imaging, radiology imaging. And in this talk, he will focus on the creation of cyber infrastructure for important societal problem to address in this talk, right?
Thank you, Lang. Appreciate the kind words. So I'm actually calling in from California, so hopefully my internet will not let me down. So my name is Raghu Machiraju, as my good colleague Dr. Langley introduced me as. So I'm certainly a professor of computer science. So anything I say, okay, please use your own filters. Okay, I'm not a clinician by any means. I work a lot with colleagues in the College of Medicine. And what I'm going to present today is essentially a project, a team science project, as as the speaker before me mentioned. So it's a team science project, but it's a modest team science project, funded by the National Science Foundation, a very different, funding agency from NIH. So, but it still, gave us some windows into, what goes on in Appalachia, especially with respect to, the adoption of technologies, right? So, and also, it also gave us a window into what's available and what's not available. And I come from India, as you can guess, right? So, and I can certainly say that many things we saw was not that far removed from what we saw in India. Okay, so especially network access. So wanted to at least tell you our experience, and I'll be happy to answer any questions. So let me start. So I think I can share my video. Okay, yes, I think, yeah, share screen. So is the screen sharing automatic, or is it okay,
At the bottom, Raghu, you should see the share screen icon, and then you could
just pick. I'm sorry.
Okay.
Can you see my screen now? Okay.
Yes, we can.
Let me start. Okay. So give me 1 second. So okay, you should see it in full presentation mode. Okay. So this is a subset of the team for the project. And you can see some familiar faces, okay? I'm not talking about Jackie Chang and Chow Yun Fat, okay? Those are, I couldn't get the mug shots for my colleagues here, so I use them. But Pam Salisbury, Bev Stringer, they're part of CCTS, right? And I.S. Haider, many of you might know him. So this team essentially includes, it's multidisciplinary, right? I mean, Pam is in public health, Bev is a wonderful on the grounds person. Is a public health professor. Jenny is in my lab, she's a research scientist, with background in biology and computer science. Anisha Arora is my chair, and a colleague who was part of this project. Jack Tiang, who actually works with Lang Lee, right? So he reports to Lang Lee, and Yang Fu, who is a student of Anish. Okay, so you can see there are many different kinds of expertise brought to bear upon this problem, and I'll go through first the bigger problem, right? What exactly is this project all about, and then I'll dig into the network, broadband access issues in Appalachia. So it's really a story of translation. Okay, so this project was started when I was the interim lead for translational data analytics. So we were not a were not part of the NSF, National Science Foundation, in a big data network. So my goal was to somehow make us part of the big data network. So National Science Foundation created this network of hubs and spokes, right? So there are, 4 hubs, one in Northeast, situated in Columbia, one in South Georgia, Georgia Tech, then one Midwest, Illinois, Urbana-Champaign, and one way out west, okay, in Berkeley and Seattle, okay. So we certainly belong to the Midwest, you know, hub. So especially all the universities in the state of Ohio. So I reached out to them. We reached out to them and asked them, "Hey, we would like to be a hub. There's a competition. What would be the best way to become a spoke? Okay, how could we do that?" And the response was, there's a lot of stuff going on in developing technologies for urban areas, but this was 2017, right? You know, think about something that will be of value to rural America, right? And maybe something of value, in a societal sense. So the opioid epidemic was certainly is still a very big topic, right? So and we felt that we should at least think of a response, because we're also a data science institute. TDAI, was created, created because we wanted to use big data for social good, right? So why not actually put our heads together, think about what would be the technical response, right, to a societal problem. Okay, so this is how this whole project got started, and there were many components, right? And 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 these are at least the big, when you consider the agenda of the Midwest Big Data Hub. They talk about health, they talk about manufacturing, transportation, and food, network sciences. I mean, it's a huge set of huge canvas, right, of different topics. But this is something new, and we were glad we applied, and we actually won, right? And to assemble a team, right, you know, we reached out to Raid Ghani, who was then at University of Chicago. He's very well known in applying machine learning to problems in problems of importance to society, right? Fighting crime, so that there's little bias. There is also Amit Shet, who is now at South Carolina. He was earlier closer to us in Dayton, and he was at Wright State University, and he applies a lot of social media tools to understand problems of mental disease and so on. And then there's of course our friends at Nationwide Children, Simon Lin and others. So we thought we should put together a community driven engineering solutions to combat substance abuse prevention in the rural Midwest. That's the title of the project. So I'll essentially say a little bit about how we had built the cyber infrastructure and some parts of the cyber infrastructure. This problem, or the solutions to this problem, are really much beyond the scope of this modest project. But like I said earlier, it did give us windows, and I'm going to share some of those insights we gained. So as this is a map of the opioid, epidemic in circa 2017 or so, or maybe even a little earlier, right? So, and of course, Ohio, is certainly, is one of the epicenters, and all the red areas, right? All the red counties, were the ones, are still the ones, which are bearing the brunt of this epidemic, right? So we came up with some, with a plan on how to engage with that community, and then, provide them with tools, right? So what's the state of the art, right, with respect to, addressing, let's say, an incident. So take a typical, public health county official, right? There's a checklist, okay? And again, we don't have to go through the entire checklist, but there's certain things they have to do. But from a very computer science perspective, what you're looking for is some kind of a workflow. Okay. And this is what folks in IT do, right? They essentially create workflows. Okay. So you could create a workflow for the county official. Okay. And again, the actual details are not that important. And there's also a scenario where a social worker has to perhaps help a certain patient, a subject, maybe help that person get help, right? At a medical facility. So so these are all workflows that could be put together, could be conceptualized, and then perhaps automated, right? and and this is one of our goals, right? How do you find all those scenarios? How do you actually automate those scenarios? How do you make the job of the county official easy? How do you make the job of the social worker easy? How do you make generally, how do you help the afflicted folks deal with social determinants or overcome social determinants, right? So that's the kind of that was the kind of project we conceived. Okay. And there are some solutions, right? So Ohio Department of Health has provided open source tools. These are very basic though, right? So you have to build on top of them. By the way, it's okay to interrupt me anytime. Okay, so we can certainly talk more towards the end of this conversation, but you're free to interrupt me anytime. So one of the problems with taking all these open source tools from Ohio Department of Health and making them useful for different stakeholders is that the data is siloed. It's all over the place. Okay. And again, you know, most of these counties are, they're under-resourced. Even having access to, a large number of printers, is not possible, right? Modern printers and so on. I mean, these are the kind of issues we were facing, right? Forget, supercomputers, forget, all kinds of, IT technologies at their disposal. They just didn't have it, and they were very ill prepared and under resourced. Okay, so one of the first things we did was like, let's build a data commons, right? And again, we leveraged many of our networks. Again, as I said, the grant was modest, in terms of financial resources, but we reached out to NSF. NSF has a lot of resources, especially in this space. So we reached out to them, and we put together a data commons. Okay, and so we call this data commons. We used to call it OpenOD, but now we call it Commons OD. Okay, so OD, is the opioid, epidemic, and Commons is essentially a place. This goes back to the Boston Commons and all the it's in metaphorically similar, where you gather together, right, and then exchange data, or perhaps put your own data, and others will pick up your data, or you pick up other people's data. That can add tools to this commons so that you can explore, visualize, analyze the data. So it's really a watering hole, right, where you come and exchange ideas, on topics of interest, right? So we created one for the epidemic. We certainly because of the COVID, we had to stop a lot of ongoing activities, and we essentially responded to the COVID pandemic also, and we did create a data repository that could be used by all COVID researchers. And then, of course, since Ayaz is part of the team, and he's very passionate about food insecurity, we also have a smart food sheds, data commons. Okay, and you're all welcome to, if you Google Commons OD or COVID Commons, you should be able to access these data commons. And also there is a front end that we are standing up. And this front end, is essentially coming through Cura, yet another center on campus. So they are our partners. As you can see, we are partnering, right, as much as possible. Okay, so, and the idea is to, again, to visualize that, right, the trends across these counties of interest, or essentially the states and so on. So this tool is not available yet, but it will be available very soon. Yeah. So part of this project is to collaborate with local communities. And we had some town hall meetings, right, with lots of interviews, right? And the goal is to create scenarios, right? So these scenarios, which I talked about earlier, we just did not want to make them. We wanted to basically inform ourselves so that these scenarios would be meaningful to different stakeholders, right? And certainly again, once again, tapped into the ATRN and other networks in the area, and also through a good friend, Bill Miller, right? So I mean, he already had many boots on the ground. So and we used them for a variety of purposes, okay, to help us with the surveys, with the interviews, and you will see soon, right, to essentially even to understand the nature of the network, right, the broadband network, the wireless network. Lot of his folks helped us collect some data. So he has been a great partner, and we thank him very much for all the help he has provided to this project. So that was certainly one very important element, getting the pulse of the community, right? Then second is to build cloud amenable. Everything is in the cloud these days, right? And although the networks are really low in speed, especially in Jackson, Scioto, and Pike counties, those are the counties of interest, we still thought we should build these tools, and then maybe figure out how to empower those communities, again, whatever way we can, right, to access the data on these cloud-based repositories, and also build tools, right? So that was essentially the second goal. Okay, so the data commons essentially has this kind of an architecture. Okay, there is an archiving technology baseline, right? And there is certainly going to be some computing, compute power, maybe through Amazon, maybe through OSC, maybe through clusters, right? That you might even own yourself, right? So there has to be both storage and computing power, but there is a lot you could do, right? You could have pointers to different data sources. You could have the data available in the data commons, and there are a bunch of services that you could provide. Okay, this is of course very aspirational, and we have again accomplished not all of them, but some of them. Okay, and this template is not my template. It's something that NIH would also promote. This actually comes from the commons, right? The genomic commons, right, at NIH. So this is one of the blueprints. Yeah. And there's also a lot of data governance that one could think of, and we have some of those in place, especially to our good friends at Nationwide Children's Hospital. One of the things that this architecture does, is to really remove the silos. Now you have everything in one place. There's a lot of metadata that could be could be created, and essentially the curation, right, which creates this metadata, really takes the silos, blows away the silos, right? And this is important. Okay, so now at least you have your ways to talk talk between one department to the other department. The Medicare data now could be connected to maybe with postmortem data, right, from the mortuary, and so on and so forth. These are all the salient. Again, I'm not asking you to read all of read all the different elements here, right? Different components. There's so many. So we do have access to different kinds of data: the EMS data, the emergency medical services data, the coroner data. I'm not saying it right, I'm sorry. And then the treatment center data, the social determinants of health opportunity, and many kinds of data sets, right? And then and I'm not going to again there's a big list, right, that we are essentially collecting. Okay, and so So all this is fine, right? So we can create this, tools, we can collect the data, but we got to evaluate it. So we do have, some folks willing to try out, these technologies. So Jackson County, especially, was quite interested, and the hope is that could we leave those tools in their hands? Could they use them? Right, that was the goal. Yeah, and so so all this is good, right? But the point is that the cloud, right? The tools on the cloud. How could you access them if the communications infrastructure is pretty weak? Okay, and what do I mean by weak? Look at this map, right? If you look at this map, the blue color essentially indicates, okay, where there is strong internet connectivity. It's mostly along the interstates, okay, and sometimes not, especially here, right, especially the lower parts, but in general, most of Ohio is certainly a desert, a digital desert. That's a a well-known buzzword. Okay, it's more than a buzzword, frankly. I apologize for saying that, but it's more than a buzzword. Okay, so it is. Some folks use the word digital desert. Some people use the phrase internet desert. So essentially, people are not connected to the world. It is a big problem. It is a big problem, and this is where my parallels with India show up, right? It exists even there, but that nation has changed, especially when it comes to internet connectivity. I can tell you one episode that I personally experienced. This was way back in 2013. I was hiking in the Himalayas with my then 13-year-old twins, okay, and my wife, of course. So we were pretty much up there, okay, in the mountains, and suddenly, we saw this guy taking care of his flock of sheep, and and talking, right? And we realized he was not talking to us. He was talking to somebody on the phone. So this is, so they somehow that nation, even with that, with a plethora of problems when it comes to internet connectivity, okay, they addressed it. It was really bad when I was growing up in the 70s and 80s, but that's one thing they did. And that's because the broadband, wherever you go, right, they have fiber all over the place. So that's happening here, but right now it's still, there are many deserts, okay, in this nation, and digital deserts, yeah. And of course we have real deserts too, but there are digital deserts. So the talk was about Appalachia, but of course I'm focusing mostly on a piece of the Appalachia. So this green part is essentially what you see here, right? So I'm still true to the to the title of the talk. I haven't really worked much with other parts of Appalachia, so I was a little diffident. I wanted to mostly talk about this project, which focused on the Ohio part of Appalachia. So, but you can see, right, there it is, I did say there were digital deserts, and you can see, this is a very interesting map from Purdue University. It's pretty parched. That's essentially the, the moniker they used. Okay, it's a parched country in terms of, digital access, right? Sometimes there are no providers, right? So and somebody has, I think an industry group, a communication industry group has done this kind of analysis, right? So we are about, we have about 15% of the households in each state, and at least in Ohio, they do not have access to internet, right? And we are not the worst, we're not the best. But remember, 15% is across the entire state, okay? It's always the last mile and the middle mile, okay, right? So we're going to talk about both. Last mile, yes, we don't have complete connectivity, especially in those counties or the Ohio part of Appalachia. We just do not have enough bandwidth, access to enough bandwidth and throughput, okay? So 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 what you see here is essentially not this, not the counties I talked about earlier, but other counties actually, closer to Athens and so on. Okay, right? So Athens, Ohio, right? So you can see that, if you do this kind of a connectivity map, right? So, so 25 is uploads, 23, sorry, 25 is 25 megabits per second is the speed of the upload. 3 is, the speed of the download. So that's how normally people, measure, right? So you can see that, there's quite a bit of, there's some red, but quite a bit of orange. Okay, so the speeds are pretty low. Okay, the internet speeds are low. So either have no connectivity or very poor, performance, network performance. So there are digital deserts. Okay, within Ohio. So that 15%, of households not having internet connectivity across the state, it makes the state look okay, but it's not great. Okay, when you start looking at individual parts of the state. Okay, so there is a broadband connectivity issue, right? It's limited, if not completely poor, right? And what you see in FCC maps, right? That's usually the best possible connectivity. Okay, these are all based upon studies, theoretical studies or analytical studies, right? So data collection is what is needed, right? You have to, collect data, and if you collect data, you'll actually learn that these maps are too optimistic. Okay, so and this is not just Ohio. This is throughout the nation. We are a big nation, right? So you'll see this story repeat over and over. For example, this is a really nice illustration I found, from this same earlier study on the digital deserts. So this is Megis County, right? Which is really part of Appalachia too. So there is only one, point, okay, which provides a very essential 411, facility, just one hub, right? And none of the other, none of the other centers, okay, on this map, okay, and as indicated by white circles, okay, they provide that particular facility. So you can see that, to really be able to, make that call, you really have to go down south in that county, right, to make that call. There are very little, and when it comes to, when it comes to, internet usage, it's very limited. Okay, and that's the point, I think, I'm trying to make. That's the point almost everybody who's concerned about this topic wants to make, right? And if you go even further down, right, it's, especially down and down to the single roads and so on, there's hardly any coverage. I was very surprised to hear that, because as I told you earlier, my experience even in the Himalayas was that, you could get signal, right? So that was really, to me, when I learned from Bev Stringer that there is sometimes no access, right? There's no connectivity. That really blew my mind. Okay, and if you look at, the internet speeds, okay, I mean, this graphic is a little bit small, but what is still of interest is that, the blue is pretty good. All the counties which are shaded blue are pretty good, but again, the ones we have some interest, okay, are in that part of Appalachia, they're not that great. Okay, and a lot comes down to infrastructure, lack of infrastructure. So 80 to 90% of the households in many of these counties don't, in the rural expanse, I think that's the word, experts use, right? They have no access to broadband services. 75%, lack availability of broadband, right? At the current, standards, right? 25.3 downstream and upstream. Actually, I said it opposite. I apologize. Okay, and mobile data and voice services, they're just not available. Okay, and so this essentially, leads to a lot of, issues, right? Beyond, because we all depend on these services for everything. Without my phone, I'm pretty much lost, right? So I mean, so the big swath of our fellow citizens, they don't have the same advantages that we enjoy, right? And so we are pretty much, so So one of our friends in the University of South Carolina, Amit Shet and others, they use, they do a lot of their analysis with, Twitter feeds and, social media. So so if you see, if you look at the use of, Twitter, right, across the nation, okay, you know, we are essentially, Ohio is certainly not one of the big users, but if you go down to, certainly, the counties, that we are discussing, it's even much lower. Okay, this is the entire, the social media, at least as manifest in Twitter, right? If you use that as one of the yardsticks, okay, we are pretty low. That drops us, right? Of what's going on, being part of a larger community, and there is certainly some correlation to, to poverty, right? There's certain social determinants probably which come in the way, right? And these are, the ones that are often identified, and many, especially the ones related to health outcomes, right? They perhaps, could be, again, I'm not an expert, I'm just, relating, what I heard and what I was, informed, by others. So certainly, in the lack of connect, there's certainly a direct correlation, with in network access, right? Perhaps these can be, they can be, there could be a causal relationship, and there is enough, enough reporting in news media. This is a not too long ago article, right? In October 29, 2020, right? So there was a pretty big there was an article in Columbus Dispatch as to how, folks are hurting, right? So, and there are solutions, right? Like what India did, right? So, if we could, have fiber everywhere, right? So we are doing that, right, in Ohio now. So, we are essentially deploying wireless broadband cyber infrastructure. I was talking to Bev Stringer, last week, and then just before the call, she told me that, the lieutenant governor just showed up in front of their office, and he was going to announce, the installation of towers, and then maybe, the creation of a more broadband and cyber infrastructure. So there are, plans afoot, right, to address this. Okay, and it's not just the big broadband infrastructure, right, which are more capital intensive, but also need for low cost novel, wireless tech, right, for sparse long range coverage. And and there is a need, and this is where Anish Arora, my colleague and chair at computer science, it comes in, right? So we wanted to first figure out, okay, what kind of coverage do we really have, right? And how does, and how could we present some of this information, to the stakeholders? So he and his team, Young Fu and Anish, they created, smartphone tools, right, to essentially, you know, to measure the connectivity. So as folks from Bill Miller's team, right, they would drive around, they were doing their usual things. They would leave this, app, running, right, on the smartphones. So, and then they would essentially, uh, you know, you know, they wouldn't do anything, right? They would just drive on, and the tool collects all the, it does a speed test, and it makes a essentially, you know, it does a speed test, and it registers, right, the measurements. Okay, and then the only thing we require, of Bill Miller's colleagues is to stop at certain places, right, and stop for a certain time so that the speed test can be done. So we did this automatic speed test for mobile collection, okay, of connectivity data, and then we also wanted to, to create a connectivity map, as you see here, right? And this connectivity map essentially tells you, it basically gives you an idea, okay, of how well, the broadband, companies, the mobile companies, how they serve these places. And this gives us an idea of, what kind of mitigation could be, or what kind of intervention, technology intervention could be conceived, right? So, so you can see, like, for example, so if dark green would mean that you can watch Netflix, right? So that's what the streaming really means, right? So the red is essentially says it's very limited. We are mostly, we are kind of green and, orange, okay? Maybe some yellow, okay? So we're not great, okay? We can do certain things, but we cannot do everything, okay? And of course this is still a limited geography, if we and I'm what we were told by Bev and others is that this could be we're still kind of in certain certain places where there is some population. Go further away, it's even worse, right? So there are significant connectivity gaps, okay, and there is certainly a need to address them through flexible, extendable and cost-effective wireless solutions, okay. Oops. So and there is Anish and others in his lab, they think about this a lot, right? So how do you solve the last mile networking problem, right? So you can place some edge access terminals. You can collect traffic from certain home access points. I mean, there are solutions, but there's also this um, middle mile networking problem, right? So you have broadband which comes to a certain point, okay, and then essentially there is maybe some signal at the end, but what about the middle, right? So this is called the middle mile network optimization problem, right? So then how do you connect local service areas to a broadband provider with minimum infrastructure costs and some throughput guarantee while leveraging pre-existing towers? So that's the kind of I guess technical approach that Aurora and others are examining, right? So, and this is one of the panaceas is the wireless meshes, and you might have heard of wireless meshes because they're now all over the network media, or there are even ads on TVs, right? How do you boost your internet, right? So you can create a network of meshes, right? And then essentially boost the middle network, right? Yeah. So what Anish Arora brings his experience in Iowa. They have similar projects in the middle, in rural Iowa, and he brings them to Ohio, right? So again, I won't go through the technical details here, but there is a way to know the lay of the land, the topology of the land, impose some constraints, and then come up with networks. So it's an optimization problem in our parlance, okay? So the set of inputs and set of outputs. Again, I will not go into the great details, but Anish will be very happy to provide more details, okay? And they are deploying certain technologies which are obtained through a certain company called Aranet, okay? And it does boost the the throughput quite a bit. So you're essentially per user, you're going up to 500 plus megabits per second, right? And they have deployed through a variety of devices, okay? And again, please feel free to approach Anish about this deployment. Yeah. So I just want to, I'm pretty much at the end of my talk. I also wanted to make a plug, since I'm an associate chair, for our department. We have a very strong networking group, and if especially with telemedicine becoming what it's slated out to be very soon, given the pandemic and everything. If there are projects that you're conceiving in telemedicine, and you're looking for good networking faculty, we have probably one of the really strong ones in the nation. So again, we have strengths in wireless networking, we have strengths in cyber physical systems, distributed cloud computing, network security, social networks, and so on and so forth. So that was just a plug for my department. I'm just being a good department chair, associate chair. So in closing, I did talk about the lack of network connectivity, and also how it exists and how there could be some technical solutions. And then and also the data silo problem and how we solved it, or how we are still solving it using um, you know, uh, open source tools, and also creating data commons, and how we have partners, in Jackson, Scioto, and Pike counties, except, because of the virus pandemic, we have not been able to engage as much. The hope is that we can, engage with our stakeholders, with our friends, and then see how they could use some of these tools. So thank you very much for listening. I'll be happy to take, any questions you might have for me.
Great. Thank you very much, Raghu, for that compelling talk and discussion about disparities in broadband access. I think it's increasingly become a critical healthcare disparity in our digital age with telehealth and telemedicine, which was coincidentally the focus of last week's talks, which we all know during COVID-19 pandemic that has even more sharply increased with provider visits, many of which are only given via telemedicine. So, I really found your statistic about the 80 to 90% of households in rural expanse have no broadband services. I thought that was really striking. And, the internet and broadband access has really transitioned from, a privilege or a want to more of a basic health need in our current age. Again, I want to open it up to questions from the audience. So you can post them in the chat or the Q&A. And I'm going to go ahead and start off with a question of my own. I was curious about, you mentioned, well, two things really. So one was, what you think maybe could be some of the downstream impacts on health equity as a result of this enabling broadband access to these underserved populations. And I think you touched on those quite a bit during your talk. And the other, which I thought was really interesting, and I wanted to get some idea about, plans to leverage some of this data. You mentioned the Data Commons 2.0 and the data repository that can be used for COVID researchers. And I wonder if you could maybe talk about if you plans to leverage that data or access that data for investigators for future research and study, looking at social determinants of health and health equity outcomes, et cetera.
So thank you for the question, Guy. So, when it comes to the first question about social determinants, okay, for example, the scenarios, we talked about scenarios. Again, I speak as a technologist, so please, use your filters, on my words, okay? So those scenarios, right? Social worker, if that person does not have access, to the internet, she's not able to find, she's not able to actually provide a solution, right, for the families, okay? So it is very profound, okay? And also, if you're, let's say, and I'm using the other scenario, right, as an example. So, if you do not know all the trends, do not have all the trends, at your fingertips, coming up with the right response is going to be a big issue, right? So we know that, there is that, at least qualitatively, there will be impact, except I do not know, right, what those numbers are and what the impact is, so I don't have real models, at my disposal. But but at least from what we've learned is that, given how important, network connectivity is to almost everyday life, like, we access, we access the cloud, to even know how much money we have in the bank, right? To set up our appointments. Many of those folks just can't even do that, right? If they're stuck in the middle of nowhere, they're just stuck. Unless somebody, comes by and, gives them a ride or something, right? So that's the kind of, I think it's a big impediment. And if I just again contrast with what we know of, what we know of, the way network connectivity impacts the poor in India, right? Because, there is somebody, I've heard stories like, the fishermen, okay, they make their catch, right? As soon as they land on shore, they can actually find out what the price is, because they call somebody. So that kind of quick access to information is something that's also it's also driving some of these these determinants. they come in the way. I hope I gave you a good answer.
Yeah, no, that was a great answer.
There was a
And I'm
second-
just,
Sorry, go ahead.
was that?
There was a second question, right? I thought there were two questions. Yeah.
Oh, yeah, yeah. Do you want me to remind you, or do you remember?
Just
It was
remind me
about,
about it. I'm sorry, it's too early for me
no,
still.
no worries. It was about the the data access that you mentioned, the kind of common the data that you were collecting about social determinants of health, and that you were integrating the data sets, and as a biostatistician, and I lead the
Yeah.
biostats epi group here, and I
Right.
know that you're all at Translational Data Analytics Institute, and there's a
Mhm.
lot of, you mentioned a lot of the excellent investigators we have there. So, CCTS is all about forming partnerships and enabling research to get done, and kind of connecting investigators that are interested in working in a particular area with opportunities, including data sources that they might be helpful for them to answer research questions. So I'm just wondering if you maybe talk a little bit about.
Okay. So, we do have these data comments. We have populated, this data comments with certain, data sets, right? And, so, to really make this a much more full-fledged, resource, it needs to have investment, right? So, I guess my colleague Tanya Berger Wolf, who's now the lead for, TDAI, Translational Data Analytics Institute, she actually, is looking into how to bring in more resources so that this can be a university pan-university resource, not just, under the purview of TDAI. So yes, plans are afoot, to make, to essentially to make it much more usable, have more tools. But right now, you certainly, you can, access data sets, and you can download data set, you can download those data sets, you can upload your own data sets, but it's not really a commons, right, at this point, right? So it's more like, a repository for, for data, right? So that's where we are right now. We have to, Tim Huerta, we have socialized this concept with him. We have, socialized it with, other stakeholders on campus. Yes, I mean, the goal is to really make it, make this a resource for the entire university, or if it doesn't stand alone, then at least it becomes part of the larger university. But at least, there is, we did make a start, and, we should have, we certainly, it'll exist in some form or shape.
Yeah, it's interesting you mentioned, so it's almost like the concept of open source data extent, that borrows from the concept of open source software, in the sense that as a user community grows, it only empowers it and makes it better. And so it really is a function of as people use it more and more, and get feedback, and it'll improve the resource. All right, so I do have a question here from Dr. Carolyn Jones, who asked, to what extent are the large corporations partnering with academia to help mitigate these gaps? Verizon, AT&T, T-Mobile, etc. Realizing that monetizing the connections is an issue in the US. And the second part to this, which is, how does India handle these costs to individuals?
So, the first question, yes, we did talk. I mean, Anish, okay, he has very good connections with, some of the providers. We talked to them that, if, of course, given the modest, scope of the project, we really didn't get too far. We also talked with a lot of entrepreneurs. We did talk to, local entrepreneurs who are interested in, utilizing the, the towers, right? The towers, essentially, which are part of the forestry service, apparently, right? So we did have all those conversations, but what was also, what we heard was that, uh, all those towers were not available, right? There had to be certain, regulations, that there were regulations that were coming in the way, and so on, right? So that essentially, is what we heard. There is interest. There is certainly an economic, there is some economic incentive for the big companies to go into rural areas. But I think, there is, at least, when we were discussing with these companies, there was not a rush. It was not considered to be a gold, part of a gold rush, right? But now with extra investment and the federal government making all these announcements, maybe things will change. We see that more and more, right? Even at NSF, right? There's more and more interest on this front. So now coming to India, again, I'm not the expert, but I'm only saying this as an expat from India. But I do know when I was growing up, there was so much investment, right? By the central government. That's how the federal government in India is called, the central government in New Delhi, to invest enormous amounts of money and capital, right, into creating the network. That created, okay, certainly a big infrastructure. I mean, not just the Himalayas, right? In the middle of nowhere in a train, I can get mobile service, no problem, right? The fiber is everywhere, okay, it's lit. And again, from what I understand, okay, there's a lot of free market, right? In terms of giving companies the spectrum. I mean, of course, there was some, there was news about corruption too, right, as to how those licenses were handed out. But there's a lot of competition, okay, for essentially providing, service. Service is really cheap, okay. Even essentially, the phones, they're much more inexpensive. Frankly, that kind of free market, access is something you don't see here. It's much more, it's kind of almost, there are monopolies here, but you don't see that in India. Again, I'm only speaking as a very I guess lay person in this domain. Okay, I'm not an economist or a technologist of that kind. Okay, so does that answer your question, Dr. Jones?
She might be muted, so she says yes, thank you. So, all right, well, with that, thank you so much, Raghu, for coming and giving a talk. And I'll make one note. It's interesting in owning today's day of Zoom. I like the contrast between our two backgrounds. We appear to be in two different seasons altogether, but
Right,
totally
right,
fine.
right. Thank you. Yeah, thank you
So I
very
guess
much.
we'll have a short break. Yes, and we'll have a short break, everybody. I guess you can stay. No, you have to actually get off this call and go on to the other session 2 call. And so that'll start at 11 a.m. So we got about 8 minutes for a break. And again, thanks so much, Raghu. I really appreciate it. And again, just thank you.
Thank you. Very welcome. Thank you for the invitation.